Sure. My name is Kim Matias, and I'm a social worker here at the St. Luke's System working in palliative care.
And I'm Nathan Roach. I am an outpatient palliative physician with St. Luke's. Also, we're at the Meridian Clinic.
Great. Okay, thank you.
All right, so today we are talking about advanced care planning in Alzheimer's disease and related dementias. I wanted to start off by giving some learning objectives. So our hope is that we'll be able to define palliative medicine and advanced care planning, or ACP, describe a framework to have an ACP conversation with a person with dementia and their family, and then identify some other resources to develop this skill set. Next slide, please. So to start off, I just wanted to give a little introduction about what palliative medicine is. And I got this definition from the Centers to Advance Palliative Care, or CAPC website. Getpalliativecare.org. It's patient-centered. It's really great to pass along to patients and their families. But palliative medicine is a specialized medical care for people living with a serious illness. It provides relief from the symptoms and stress of their illness, improves quality of life for patient and family. And we'll talk a little bit more about how that improvement in quality of life can happen with advanced care planning. It's based on the needs of the patient, not on their prognosis. So it can be appropriate at any stage or any age of a serious illness. And it's provided along with curative treatments. Next slide, please.
Advanced care planning is the process of communication to be able to learn about a patient's future care and their treatment preferences. Within those discussions, it also gives the chance to learn about a patient's values and goals. In 2019, the European Association of Palliative Care Board created Advanced Care Planning in Dementia, and this is an approach that includes the person with dementia, their family, and their healthcare team. And advanced care planning is also an ongoing process with continued conversations and documentation. These processes and conversations will also continue after the person with dementia may no longer be able to make their own healthcare decisions. Our role has been to help interpret the values and goals of the patient and the family with developing their treatment plan. I also describe this process in some of these documents as fluid documents, meaning that the purpose is for them to be adjusted over time with changes to the person's health as well as evolution of their own goals.
Next slide, please.
Some important things to consider with advanced care planning is the patient's capacity, the family, and engagement and communication. Communication is something that should be adapted along with the fluctuating capacity of the individual. It's really important the inclusion of the person dementia and their family members in this process together. They're experiencing this disease and the changes to their life together as well. We also find that we're often helping the surrogate understand and navigate a change in their role, now perhaps going from being kind of a support and consultation person to their family member to perhaps the direct decision maker. Many times people with dementia are experiencing a loss of autonomy and a loss of empowerment, and the experience of advanced care planning can really help keep them central to their health care and just validate it as being the most important person in the room when we're talking about their future.
Next slide. So when we wanted to come up with a way to discuss these types of conversations, we looked to the Serious Illness Conversation Guide. This form of the guide was created by Ariadne Labs in Boston. And the purpose of this guide is to really have a framework for talking about serious illness by assessing a patient's illness understanding and information preferences, sharing your prognosis, exploring key topics, and then documenting the conversation. Next slide. However, we wanted to see if you could go back one slide. Thank you. we wanted to see if there was something that could be used a little more specifically for dementia, and we found this, which is the Serious Illness Conversation Guide for Dementia, which was created by a team at Dartmouth, their palliative care team. You can go ahead. And it's basically a 2-page document, and we're going to be discussing really the first page in more detail during our talk today. The second page has some additional skills, just some what they call interstitial skills to help with learning about, or help be able to talk about the different emotions that go into talking about these topics. Next slide. And then you can advance again, please.
For the setup is your first step in this guide, and I'm going to use husband in the blank just so it sounds a little bit more natural as we explore this tool today. So in the setup, you'd be saying things like, I'd like to talk about what's ahead for your husband's illness and do some thinking in advance about what's important to your husband so that I can make sure we provide the best care possible. Is that okay? I'll be using a guide with me today, and it will help me make sure I don't miss any important information. Asking permission in this small way is a way to help the family and the patient maintain and be controlled and maintain control of the discussion. And also it's a cue to prepare that we're entering into a discussion that might have some serious and maybe heavy topics for the patient and family. We like to also point out the benefit of advanced care planning is to honor their wishes and avoid making decisions that might be under stress or even under a state of crisis. And you can let the patient and family know that they may not need to make any decisions today when we're just starting a discussion, but our hope is to start a process of conversations over time to best understand their future needs.
The second step in the framework is to assess, which is getting an understanding of what they know about their illness or their loved one's illness, and also asking how much information they might want to know about what may happen in the future with this illness. And we find that this varies from family to family. In many cases, the person with dementia may not want to know much information about what may happen in the future, whereas their family member might want more of that information. And in our practice, at times we will split up and talk more candidly about prognosis and disease progression with the loved one, when instead of speaking about that in front of the person with dementia, if that's their preference. Next slide.
The next step is sharing what you understand and the knowledge you have about their condition. So I want to share with you my understanding of where things are at with your husband's illness. This is going to be speaking more in generalities, saying things like memory loss is a brain disorder that usually progresses over time. This could affect people's ability to drive a car, make their own meals, use the bathroom, eat independently, and communicate effectively in the future. It's really helpful when you're having these types of discussions to use language related to the disease rather than things like, you won't be able to drive a car. We find that when we say things like that, it can feel accusatory and can also make people start to feel immediately defensive rather than speaking to the progression that we anticipate with their disease.
The next step of the framework is to explore, and to start with, we ask the loved one to imagine what their loved one, their person with dementia, would say if they were able to think clearly. And I think this gets to really the heart of our conversation, which is, what are the most important goals if their health situation worsened? What are their biggest fears or worries about the future with their health? What abilities are so critical to their life that they couldn't imagine living without them? And then are there any medical treatments or types of care that they wouldn't be willing to accept? One thing to keep in mind is some of these questions you might be able to ask directly to the person with dementia, but depending on the stage of their dementia, they may not be able to process and understand and respond with some of these more complex medical questions. So it may be that you're referring these questions to the loved one. However, if you are asking the person with dementia, you can always consider using more close-ended questions rather than these more open-ended questions, giving them extra time to process the questions before they answer. Those ways to kind of adapt to the cognitive side of, of how they're thinking is a way to ensure some success with these kinds of questions. Additionally, we do think that it is important to try to normalize these types of discussions as much as possible because it it helps to make sure that the family and patient understand that these are just regular questions that you're asking all of your patients or all of your patients with dementia rather than something that is applying only to them. We know that these can be emotionally charged conversations, and they may be conversations that they've never had before with medical workers or healthcare workers. So, really, just trying to normalize this as much as possible helps to make the process go a little smoother, we find. Next slide.
Your next step would be to work on closing. So I've heard you say that taking care of your husband in your family home is really a high priority to you both. Keeping that in mind and what we know about their illness, I would recommend X, Y, and Z. How does this plan seem to you? And we will do everything we can to help you and your family through this. This part of the process is an opportunity to implement their goals and values that they've stated into a framework of medical care and future care planning. That's really talking to families where they're at and has a much higher value than presenting them with things like statistics or, risk evaluations or things like that. It's also really important as a care team to be thinking about the promises we make. Promising that we'll do what we can is a very reasonable promise we could keep rather than something like, we'll make sure you never end up in a nursing home or that something like that never happens. Things you may not be able to control. We often see there's families that might have made promises decades ago that now they're grappling with the fact that they have a promise that's becoming very hard to live out. And so it's really helpful to think about as a team, what are the things that you're promising, committing to, and what's in your power to continue to keep accompanying through them in their care.
While we think that this guide is a good resource to use for any type of healthcare provider, we know that there are other resources out there that might fit your practice a little bit more. So one of them we'd like to share is what's called the Conversation Project, and there's the website address there. And it is an initiative of the Institute for Healthcare Improvement. Their goal is to talk about wishes for care through the end of life so that wishes can be understood and respected. And they have a lot of free resources in a variety of languages that are about these types of topics. So they have a conversation about end of life care, starting a conversation about end of life care and dementia. They have guides for being a proxy, choosing a proxy. So we found that this would be a really great resource to consider or use as well. Additionally, the Jerry Powell podcasts are a really great source of information. For those who aren't familiar with these types of podcasts, they're based on geriatrics and palliative topics. They're about 45 minutes to an hour long. And we found a few in particular that were about communication and serious illness that we thought were worth looking into and listening to.
Next slide. A couple other good resources we wanted to point out is a program called Vital Talk. This is a website as well as they have an app, and they have courses online, hybrid, and in person to learn about serious illness discussion skills. And then they also have some tools to learn about the best case, worst case modules, which is an approach of talking about some of the potential outcomes and helping a family thinking about some risk assessment along with their provider. And another skill is the empty chair framework. So empty chair is a way to invite into the discussion the person that may not still have full capacity. And it can often alleviate the burden of the surrogate feeling like they have to guess what their loved one might have wanted with all of the things that they're taking into account with the current situation. So with the empty chair, you might say something like, if your husband could talk with us today with his capacities before he had dementia, understanding all the current circumstances, what do you think he might have told us? This is just a really easy way to bring that person in the room and help that surrogate hopefully feel like they have a little bit of support to invoke that person's wisdom that they could have embarked in the past.
And a final resource that we think would be worth considering is Dartmouth's Palliative module. So through their CME website, they do have some online webinars for goals of care discussion. And they have one actually coming up next week that would be worth your time as well. It's about 3 hours long. It's $20 for 3 hours of CME credit. So it's a great deal. And they'll be using the Serious Illness Conversation Guide. So you'll have a little bit of familiarity with that topic as well. If that date doesn't work for you, you can look and see there are some other dates that are available with Dartmouth in the future. Next slide.
Our key points today were to normalize advanced care planning for all patients, including those with Alzheimer's disease and related dementias. We find that families, they're thinking about this. If we're not bringing it up, it is a topic typically on their minds. And sometimes it's really been weighing on them. When I look at a lot of guides for family members taking care of people with dementia, it's often within the first few things that they should prioritize. And families feel really, really overwhelmed with how do they even just start to step into that space. So we can often be a guide and a support as they start to have these discussions and ask and express their questions. Using the SIGCD framework as a guide for your ACP conversations with patients and families, we hope we've given you a good tool today. We also know that feeling comfortable with these types of conversations take time and experience, so that's really important to think in your own practice. And we've been doing this for years, and sometimes we're still like, well, we're learning all the time. It never ends. Advanced care planning discussions can really help support patients with dementia and their quality of life, helping them to continue to be the focus and priority of their health care all throughout their life and disease condition.
And here are our references. In particular, we would like to say thank you to Dartmouth Health Palliative Care and Dr. Cullinan with their team for allowing us to use the Serious Illness Conversation Guide for Dementia, as well as giving us the information about their modules. And on our last slide, we have our email addresses. If you wanted to, I don't know if we had that on the current one. We can put that in the chat if you had questions for us beyond this.
My apologies, I shot it too soon. I'm going to put that in the chat really quick.
Okay.
Thank you. So yeah, let's, thank you so much. That was fantastic. I will put your contact information in the chat.
Okay.
Abhilash, I saw that you had a question to kick us off. Let's talk AI.
Yeah, so, great presentation. And again, all this requires so much time, sensitivity, maybe training. And so people who come to you are very fortunate, but for every one person that comes to you, what about the other 99? You have any suggestion for primary care world?
So I think having a primary care provider use this framework is an easy start because we understand as well that for every patient that we see, there are many that are not making it to our clinics. So I think either using these tools or using something like the Conversation Project would be a way for a primary care provider to have some more tools in their tool belts that they can use when they are trying to have these types of questions with their patient or these conversations with their patients.
Thanks. I heard that AI might be used to teach residents and students about palliative care because it requires a lot of patience as to have that kind of patience and compassion for a long time, you know.
That's interesting. AI, I just recently graduated from fellowship, but even in my fellowship, AI was not much of a thing yet. So I don't know how how it will affect future training for residents and fellows.
Thank you.
Oni, I see you're unmuted. Let's go to you next.
Well, just being on the nursing home side, I think it's really important that you guys focused on having these conversations prior when people are ideally still being more able to be involved. Sometimes when somebody's in a nursing home or in the hospital, it's not the wrong time. It's always a good time. But I really appreciate you focusing on having those conversations earlier. So from my end, thank you.
Wonderful. Do we have any other questions? You can put that in the chat or unmute. And Amy, thank you for another resource that she put in the chat there. Another serious illness guide conversation or conversation guide. Thank you so much.
Well, what about management of agitation? If you guys can share your tips.
Sure. So I try to use the DICE method where you're describing what the behaviors are, investigating potential causes of agitation, creating a plan, and then exploring and evaluating what's working or not working. So I really try to focus on, are there reversible causes? Is there untreated pain, constipation, urinary symptoms that are contributing? I look as well to see if potentially there's some undiagnosed or undertreated mood disorders that are contributing as well, because I find that more often than not, those can be significant drivers of agitation in patients with dementia. From there, I always try to give a range of treatment options with patients and their families, whether there are as needed medicines that are less harmful or have fewer side effects, like trazodone, versus medicines that may be more beneficial but more side effects, like a antipsychotic. I I find that patients and their families respond really well to that, and we come up with a plan together based on that rather than just going to one or the other.
Thank you. Thank you.
We certainly also do some caregiver training, which I know many of you on this panel do from, I know, a lot of your work. So, helping caregivers think about new ways to respond to the behaviors, because we find often, sometimes they're describing us the same situation for maybe even 8 months before a suggestion that we might make kind of lands, but giving them maybe new language or new ways to approach a behavior that their family members presenting, things like, just simply just like not correcting them that they're wrong all the time, or even helping the family reframe that they won't do things to, I think maybe just now they just can't organize the information to do it anymore. They just aren't able to. So, like many of you, we also just try to do a lot of caregiver training to help find new ways for them to live and cope with the behaviors that they experience from their loved ones too.
Fantastic. Thanks.
Great questions. Anything else?
No, and I thank you. I really appreciate what you just said about caregivers. And I think what I was thinking and this is a wonderful presentation. Thank you so much. These are a couple new resources to me. So thank you. I think what I was thinking about, well, I know what I was thinking about was around caregivers and just that ensuring that the right people are in the room. Because we hear these stories of, oh, well, one day the brother dropped by, like the brother that usually doesn't do anything happened to come that day and they had this serious conversation. So just that, and then suddenly you have trying to figure out what kind of extricate information from a brother who wasn't ready to hear the information. Or whoever. So I think the more I can be thoughtful about having the right people in the room at the right time to hear the information, kind of be mindful of those information gatherers and the caregivers that are doing the heavy lift, to make sure we're all kind of speaking the same language at the end of the day. But this was wonderful. Thank you.
I think that's a really good point, Sheila. And I also just think that made me think of just one small thing to say is sometimes we also need to try to set the pace of the conversation. So sometimes patients could participate, but the family isn't really giving them the processing time. And so we might do a little bit more to really be able to get them more voice by telling them, let's just give a minute here. I'd like to see, I think your mom's wheels are turning. Let's give her a second. Sometimes they may have more ability to participate and give us information than the families used to. We see families sometimes really getting used to answering and over talking them. And so we just try to delicately navigate that and see if maybe we can reframe some conversation skills of their own family.
So I just want to pipe in on how occupational therapy can be a complementary service in palliative care, but also agitation in general. As a profession, we're natural problem solvers, so we're gonna come in and help dive down with that DICE approach, but just also figuring out who that person is and what their wants are for end-of-life care for palliative. What do they want to most do, and what are the barriers to them doing it? So that's where the problem solving would be. And OT is all about helping people do what they want and need to do every day, but finding ways that they can do it as independently as possible. And sometimes agitation comes in when the challenge is too hard or too easy. And so helping find that just right challenge with the tools that we have in our toolbox of looking at the environment and the people around them and education and all of those things. So I have worked with palliative care before, or just that end of life care, and it's a great place to be because it's so satisfying to help people do things that they want to do as long as they possibly can.
Wonderful. Thank you, Joanne. Nathan and Kimberly, I'm wondering if you, thinking of those caregivers, what tools you have for the caregivers for those families to share information with other family members after the conversation. What does that kind of continuing the conversation? What does that look like?
Like once they go home from our clinic appointment.
Sure. Yes.
Obviously that does vary some, but sometimes we might just give them a little bit of a script to take home. I might just introduce a phrase and say, maybe this is something you could say to your family. We also invite that discussion, to be honest. We also recognize that they might need our support to have that discussion with the whole family. So we welcome them to include family members in future visits so that we can navigate the questions and concerns that come up. The caregiver doesn't have to be also burdened with explaining it, answering all their questions, and answering everybody's worries. We offer that a lot. Very few families do take it up, but I think sometimes just being empowered that we could be there for support if the conversation goes bad it makes them feel a little bit like, okay, I have a backup if things really go, really sideways or get incredibly overwhelming. So those are a couple things that we do.
Wonderful. Thank you. We do have a question about sleep. I think it's a bit different from our current conversation, and I'm wondering if one of our panelists can kind of take a stab at that particular question related to supporting sleep disturbances and especially that caregiver that is suffering. If we can have a conversation on the side, that would be great if there's some resources there. Any other questions for Kimberly and Nathan? Well, thank you. This is such an important conversation. We hope it will just continue to inspire future conversations with our people with dementia and with their caregivers. So thank you so much. Great. Looks like we've got some resources popping up in the chat there as well. So thank you.